Are we live?
Yes, sir, we are live.
Yes. Thank you very much. Good evening, all the friends. We would like to welcome again Professor Soshi and Professor Negayama for this wonderful webinar about the HIP series. And we have another speaker, Dr. Raghavendra. He'll be also presenting one case. He has been regular speaker in our this series, and we have Dr. Prakash and Dr. Satish Kunar as moderators. I'll hand over to Dr. Prakash, and then we immediately start.
Yes. Good evening, everyone. At the outset, I would like to thank all the speakers for having accepted and they are about to enlighten us about the management of hip arthroscopy. I think in India, hip is widely picking up, and this talk is very important for us to understand how the hip arthroscopy world works. I would like to welcome Dr. Takahiro Nagayama for his expert talk on capsular management in hip arthroscopy. And this is very important now because there is always a controversy if you have to do a capsular closure or not. Let's hear what he talks about capsular management. I welcome you, Dr. Takahiro, and the stage is yours.
Good evening. I'm Takahiro Negayama. Can you see my slide?
Yeah, it's clear. We can hear you. We can see you. Yes.
Thank you. Okay. I'm going to talk about capsule management. Today's agenda. Number 1, anatomical consideration. Number 2, history of capsular management. Number 3, periportal capsulotomy access. And number 4, surgical technique. Number 5, outcome. The hip capsular ligaments includes the iliofemoral ligament, ischiofemoral ligament, and pivotfemoral ligament. The iliofemoral ligament is the strongest ligament and resists extension and external rotation, thus contributing to hip stability as a stabilizer. A previous study revealed that the capsule is most widely attached to the inferior margin of IAS. There is an anatomical study looking at which nerve supplies hip joint capsule. They find the femoral and obturator nerve supply anterior surface of capsule, while the nerve to the quadratus femoris supply posterior capsule of the hip joint. The anterior capsule primarily supplied by the femoral and obturator nerves, and the superior labrum appear to be the primary main pain generator of the hip joint, given their greater density of nociceptor and mechanoreceptors. Next, history of capsule management. In 1931, Dr. Berman first reported on hip arthroscopy. In 1939, Dr. Takagi reported the first clinical application of hip arthroscopy. These two surgeons described it was impossible to get the scope into the joint between femoral head and the sternum. Since then, there had been no reports regarding hip arthroscopy for 4 decades. In 1986, Dr. Erickson reported hip traction, which is the basis of the surgical procedure we perform today. This was breakthrough on hip arthroscopy. And then hip arthroscopic surgery has been dramatically evolving. In 1987, Dr. Glick reported the first description of capsular management. He reported penetrating the capsule and placing a trocar to approach the intra-articular space laterally. In 2003, Dr. Gantz reported the concept for FAI. After this report, arthroscopic surgery for FAI has increased. In 2005, Dr. Sampson reported arthroscopic management for FAI and capsulectomy. There were no problems of instability from the partial capsulectomy. Approaches to improve intra-articular operability and vision have been reported. In 2007, Dr. Felibon reported capsulotomy from the anterior portal to the anterolateral portal to anterior portal. The capsulotomy was closed between the anterolateral portal and anterior portal. 2011, Dr. Bird reported on interportal capsulotomy. A capsular window was created by connecting the anterior and anterolateral portal. However, capsular repair was not mentioned. In 2009, Dr. Matsuda reported iatrogenic hip instability. He reported a case of progressive osteoarthritis of the hip joint after interportal capsulotomy. He showed that a large capsule incision, such as interportal capsulotomy, causes joint instability. Many practitioners started to consider capsular repair is really important to solve this problem. 2013, Dr. No reported T capsulotomy and routine complete closure. The main methods of capsular repair to avoid instability are the use of the Quebec City slider, as reported by Dr. Philippon, and the use of the shoelace technique, as reported by Dr. Uchida. Dr. Oki reported capsular repair for symptomatic hip instability after previous hip arthroscopic surgery. Dr. Uchida reported systematic review showing patients who underwent capsular repair in conjunction with other arthroscopic hip preservation technique had better PRMs and a lower incidence of DHA conversion. Although good results with capsular repair have been reported, as in these reports, incisions in the iliofemoral ligament are invasive. The iliofemoral ligament is the strongest hip capsular ligament and is the most important static hip stabilizer. Interportal or T capsulotomy can cause damage to the iliofemoral ligament and hip instability. Dr. Murata reported biomechanical studies on suture for hip capsular closure, shoelace and double shoelace and Quebec City sliders. The shoelace suture, double shoelace suture, and Quebec City slider are more effective than standard suture. However, the native status is stronger than any other suture. With these results, an approach that preserves as much of the capsule as possible was reported. Dr. William reported on performing puncture capsulotomy using 4 portals. Dr. Alan Chan reported periportal capsulotomy. It is a minimally invasive treatment that uses small portals to perform intra-articular procedure. He reported that interportal capsulotomy and T capsulotomy induced hip instability. At the part of incision made by interportal capsulotomy, the highest prevalence of nociception immunoreactivity was observed. Next, I'd like to talk about periportal capsulotomy access. This is an evolving form of capsular management at Wakamatsu Hospital. We used to perform partial and complete capsular repair. We started performing shoelace capsular repair in 2017 and periportal small capsulotomy in 2023. Periportal capsulotomy is the current trend for FAI surgery using a small portal of ALP and MAP. I will show the surgical technique used in my case report. 18-year-old man, handball player, presented to us complaining in bilateral hip pain, and the alpha angle was 88 and 84, suggesting the prevalence of a CAM lesion. For better viewing, we passed the suture through the capsule near the portals. The incision was pulled up to create a wider space between the cam and the capsule. This movie shows periportal capsulotomy access for FAI. First, we dilated the MAP and ALP. Portal was spread to the outer layer of capsule, and the cannula was inserted to improve accessibility. Limb resection was performed to expose the limb, and the limb trimming was performed. By using cannulas, it makes it easier to access the portal. We found the labrum was hypoplastic, so labral augmentation was selected. We prepare grafts using ITB. We use a 1.5 millimeter suture anchor, microraptors or Q-fix to fix the graft at the most medial side of the labral defect. Next, the graft was fixed at the most lateral side. Additional anchors were placed at 1 centimeter interval to fix the graft on the top of the native labrum. After hanging the capsule, we performed cam osteoclasty. Viewing from MAP versus ALP. The femoral head was spherical in shape. Finally, we performed capsular repair for only MAP. Post-operative X-ray confirmed good spherical shape of femoral head contour. I will show you the short-term clinical outcome of our periportal capsulotomy procedure. 9 patients who underwent bilateral hip arthroscopic surgery for FAI were reviewed. Interportal capsulotomy was performed at previous surgery, and periportal capsulotomy was performed on the other side. Visual analog scale was measured at 1, 3, and 7 days post-operativity. VAS score at 7 days was significantly lower in the periportal group than in the interportal group. Moreover, periportal capsulotomy improved post-operative pain more quickly. Periportal capsulotomy with repair in hip arthroscopy could be less invasive, less painful, and significantly impact the outcome of surgical procedures. With proper technique, patients can expect an excellent outcome and return to play activity. Thank you for your attention.
Great talk.
Very nice presentation, Dr. Negayama.
Very nice.
Thank you.
I have got a question. Nowadays, people accept that any place where capsule can be left without closing, even in periportal access, or do you close all the capsules, or if you leave all the capsules, is there any place, or how do you deal with that?
Sorry.
Do you close all the capsules?
Only we close only MAP.
Okay. Professor,
Okay. So MAP, only MAP repair is MAP is usually located in iliofemoral ligament, the
Yes.
center of the iliofemoral ligament. The iliofemoral ligament is most important to stabilize for the hip joint. And the ALP is just between the iliofemoral ligament and the ischiofemoral ligament. Just only, you know, like a rotator interval ALP position. That's why
Yes.
only we are thinking about only MAP is important to stabilize joint after surgery. And the ALP
Okay, sir.
leave open is also important to drainage of the hematoma, interarticular hematoma.
Okay.
Sometimes interarticular hematoma is a higher pressure to is called the femoral head.
Okay.
Sometimes femoral head is like going to be necrosis or osteonecrosis like this. So that's why just
Right.
leave open.
Sir, one more question is what is your suggestion for young surgeons who are starting hip arthroscopy, whether to do intercapsular access, interportal access, or periportal access?
Negature.
そうですね。For beginner, I think it is easy. Periport, interportal custom is easy.
Really?
Okay.
そう思います。
Really?
I have a question, Harish. Is there
Sir, please.
incidents where you have got hip stiffness after tight capsular closure? Is that a possibility? Because we know synovial proliferation happens, and like in shoulder, sometimes we seldom do capsular closures, but there is a little bit of stiffness that is happening there post-operatively. Is that the case with hip also? I just want to know. I'm just curious to know if capsular closure can cause stiffness.
What I mean? Okay, that's a great question. Now we are doing a periportal capsulotomy approaches. Only repair the capsular in the map border. So there's a less incidence of capsular tight stiffness. But when we used to perform interportal capsulotomy, we used to perform shoelace capsular closure using ureter tape, fiber tape or ureter tape. Sometimes some patient with shoelace or double shoelace capsular repair is a it's like a tight stiffness, the anterior capsular stiffness. Those patients the recover is slower, and sometimes complain the tightness of the stiffness and anterior pain as well.
Yeah. And how do you overcome that problem? Is that with physiotherapy, or you go inside and remove the sutures? How do you overcome that problem, sir?
Yeah, that's great question. Yeah, that's great question. Yeah, so usually the physiotherapy can help those patients, but sometimes it's not helpful. That's why for those patients is who are not eh, not reactive to physiotherapy, I usually do ultrasound guided injection on the,
Okay.
with a stiffness side or adhesion side.
Like arthro distension. Yeah.
Yes, that's right.
Yeah, that's a great idea. Thank you so much.
Thank you so much.
Hello, sir. I have a question for you. This adhesive capsulitis hip, I think this is one entity which is grossly overlooked. Just like we have a adhesive capsulitis shoulder, I think there are few patients where they complain of hip pain when the X-ray being normal. But I had a couple of patients where X-ray being normal, but there was a gross global restriction in the movements of the hip. So I came to a diagnosis of adhesive capsulitis hip. So what is your take on adhesive capsulitis hip? Do you operate in such patients with the capsular release or capsular thinning, or you do conserve with the physiotherapy? What's your take on that for adhesive capsulitis hip?
I'm not sure. I'm not sure those patients. So, what do you diagnose those patients? Maybe a capsulitis, severe capsulitis, either synovium, severe inflammatory the patient diseases. We have to rule out the rheumatoid arthritis or systematic inflammatory diseases. And then if we see the labrum tear on the MRI or FAI patient, I do arthroscopic surgery first.
So do you believe in idiopathic adhesive capsulitis hip, that they do exist, such patients? No, without any other idiopathic adhesive capsulitis hip, like in, for example, say uncontrolled diabetic patients.
I don't think there is an idiopathic capsulitis. Yeah, maybe
always coexisting pathologies.
Yeah, the vast majority of the patient with capsulitis is caused by a secondary, like a FAI or osteoarthritis, right? Yeah.
Right. Okay, I think, okay, sir. So I have another question. We have already spoken about that in previous discussions. Like just like in Japan, we also have similar kind of patients, like the globally overcovered pincer kind of patients, which are more commoner than CAM in our Indian population as well. So they are tighter hips, coxa profunda, pincer patients. So how do you manage in such patients regarding the capsule? Do you always close even in tighter hips, or leaving out without capsular closure is fine for you in such patients?
Oh, that's a great question. Pincer type, the global pincer type of coxa profunda patient in Japan, I think it's the rate of incidence of pincer or the global pincer type of impingement patient is really low, really low. Maybe compared to the Indian patient. Yeah. Those patients have a severe limited range of motion. And also capsule, in my experience, the capsule thickness is much it's thicker than dysplasia patient. So those patients, I think only partially closed capsule is enough. But left open, if you do the interportal capsulotomy and the left leave open, the leave open the site can cause the adhesion between the osteoplasty site. So you have to pay attention to adhesion between the capsule, interportal capsulotomy and the osteoplasty site. That's why to avoid adhesion osteoplasty side, I recommend close the capsule or periporal capsulotomy approaches.
Closer. Okay, one last question. What is a normal capsular thickness on an average? Normal capsular thickness.
That's great question. It's usually the literature saying, ネガちゃん、MRI でノーマルな関節包の厚さっていうのはどれぐらいですかって。報告で。
どうでしょう。About 5ミリぐらいですかね。どうなんでしょ
I think 7 millimeter to 10 millimeter.
Okay.
Yeah, literature saying, but maybe the very individual or very, the capsular
Subjective,
thickness
right.
very,
Okay.
very ethnic.
Okay.
Yeah.
Okay. Okay. Right.
Yeah.
Thank you, sir. Thank you so much.
Thank you so much. Thank you for asking. It's a great question.
Thank you.
Thank you.
Yeah, we welcome Dr. Satish Sonar, one of the top hip arthroscopy surgeons in India. And I think
Good
we'll
evening.
move on. Hello, sir. Good evening.
Good evening.
And
Sorry for the
we'll-
sorry for the
It's
delay. I
okay.
was in examination patient.
Yeah. So we'll go to the next part of the exciting talk from
Yes.
Professor Sochi Uchida on the labral repair and reconstruction and augmentation. Over to you, Dr. Professor.
Okay, let me share my slide. Can you see my slide?
Yeah, we can see it, sir.
Okay.
Yes, sir. Yes, sir.
Can you hear me?
Yeah, we can hear you. We are seeing your
So-
slide.
Do you see only slide or
No, we are seeing the presentation mode.
presentation mode? Okay, let me.
Yeah.
Okay. Presentation mode, right?
Yeah.
Yeah.
So down on the right side.
Yeah. Can you see my slide, right?
Yes. Yes.
Yes, sir.
Oh,
Okay.
Yes. We can see your slides.
Yeah.
Yeah,
Today
it's fine
my
now.
talk-
It's fine now. Yeah, thank you.
It's fine. Okay.
Yes.
So today my talk will be labrum preservation technique, the labrum repair and augmentation. This is my disclosure. Today's my agenda is today's lecture focusing more on labrum repair and labrum augmentation based on the periportal tiny capsulotomy access. So lower labrum, acetabular labrum is suction sealing effect to stabilize the joint. And shock absorber and nociception. This is a prospective registry data looking at mid-term clinical outcome, labrum repair versus debridement. They found 2,025 labrum debridement, 55%, and 1,659 labrum repair, 45%. Both groups significantly IHOT-12 and EQ5D improved post-operatively, but there are no significant difference between both groups. In addition, this is a systematic review looking at midterm clinical outcome, labrum repair versus debridement. 364 patients with labrum repair versus 318 patients with labrum debridement in 7 studies. So they found improved PROMS was observed in all studies at minimum 5 years follow-up. And the rate of THA and the revision rate is reduced in labrum repair group. So recent literature it's saying labrum repair is superior to labrum debridement. And this is a recent study looking at low acetabular labrum size. So Dr. Philippon's group reported they cadaver studies. They divided into 2 groups, small labrum group. The labrum width is less than 6 millimeter, and the large labrum group is labrum width greater than 6 millimeter. So they found distance to the suction seal rupture is labrum large group is distance is 7 millimeter, and the small labrum group, the distance is 2 millimeter. The labrum height was largely correlated with all suction seed parameter. Moreover, Dr. Maldonado is reported 2022, load was stable labrum size. They made a model, Cadman model, large labrum reconstruction circumference reconstruction model, and small labrum reconstruction model. And they found reconstruction labrum group is 6 millimeter better stored destructive stability compared to the small labrum group. So labrum augmentation for hypoplastic labrum is in case of remaining labrum is inadequate to restore the hip suction seal mechanism. However, viable remnant of labrum circumference fibers are present. The graft has several laws. Labrum tissue reinforcement and the special tissue between the labrum capsule to prevent the formation of adhesion. So this is our algorithm of the when to repair, reconstruction, or augmentation. If you see the labrum pathology, but here with highly volume, we do repair with suture anchor. If you see the absent or calcified segment of the labrum, we do reconstruction with IT band autograft. If you see the degenerative and or decreased volume of less than 6 millimeter, we do augmentation with IT band autograft. Just leave the native labrum. So this is a periportal small capsulotomy access to MAP and anterior. So MAP portal and anterolateral portal. To access to the anterior superior labrum, we use a curved guide through the MAP portal in the cannula, through the cannula. And the curved guide from anterior to the 3 o'clock to the 12 o'clock position. And then afterwards, to access to the posterior superior labrum, scope viewing from MAP and curved guide put through the anterolateral portal, and we can access to the 12 o'clock to the 10 o'clock position to repair the labrum. And this is the movie showing how to use the arthroplasty. So you can see here, if you put your thumb in the ring of the arthroplasty, you can only move prospination is 45 degree, only 45 degree. If you thumb out of the ring, pronation and supination 180 degrees. Okay, and direction of arthroplasty suture. So put in the cannula from anterolateral, scope viewing from anterolateral border, put the cannula into the MAP border, and arthroplasty reach out to the limb behind the labrum, and then you can see here concave shape of the acetabular labrum, and the concave shape on the arthroplasty is a complete opposite. That's why you can feel like a stuck behind the labrum. That's why you can rotate the arthroplasty to penetrate the labrum. So the position of anchor, scope viewing from anterolateral border first, and then to access to 2 o'clock position first, and then gradually from anterior to the posterior to place the anchor to repair the labrum. And then you place the suture anchor 2 o'clock position, and then one of the suture penetrate between the labrum and the condylar junction. And then arthrophias penetrate the substance of labrum and then grab the loop and all the way pass through the outside the cannula, and then the same end of the suture put through the loop, and then all the way pull down. The suture reach out to the limb, and then you can see here the last loop. You can do the last loop technique to suture repair. Okay, this movie. Okay, and next. To access to the posterolateral superior labrum, scope viewing from mid-under portal, and curved guide from 11 o'clock to the 10 o'clock position. So how to perform the labrum augmentation? Scope viewing from anterolateral portal, and then you can see here, this is the transplantation site. We can measure the size of the graft, and then using liberator or whatever you want. And then we place the suture anchor each end of the transplantation site. And the scope viewing from mid-under portal and scope placed to the posterior end of the transplantation site. I recommend a different suture color. And then each end of the suture passes through the native. This is the native labrum. And then unsuture passed through the suture, grab through the map portal, and pass through the suture, grab, retrieve the anterolateral portal, and then pulling out to make it longer, mid-anterior portal suture. This is a leading suture, the graft, and then the graft harvested from ipsilateral iliac IT band, and then suture both ends of the graft, and then past pulling suture from anterolateral portal. This is a leading suture, and passed through the slided into the through the map portal, and then graft into the position, and then tying knot both ends of the graft. And then one of the additional suture anchor, the mid substance of the both graft and the native labrum, and tying knot for the secure graft fixation. This movie showing scope viewing from mid-under portal and dilation and to improve maneuverability and accessibility to the scope and you can see here, this is a hypoplastic labrum, and then limb recession and this exposed limb, and then limb trimming was performed. And then you can see here, this is the 5 millimeter width liberator. We decided 3 centimeter transplantation site, and then pass through the one of the graft through the suture, and then suture passed through the labrum, retrieve the anterolateral portal, and then pass through the suture, grab, retrieve the this is the mid-under portal cannula, and then make it longer to middle anteroportal suture, and then tying both ends of the graft, and then slide it into the graft into that joint. And then each end of the suture, tying knot to repair the graft and the native labrum as well. And then an additional anchor pass through the graft and the native labrum, and for the secure fixation. This is a 6 mm width of the labrum augmentation. Take-home message: hip arthroscopic labrum repair and augmentation through the periportal capsulotomy access provide minimum invasive yet effective approach to addressing labrum pathology in the hip joint. Effective labrum repair and augmentation are crucial for restoring the biomechanics of the hip joint, improving stability, and preventing future joint deterioration. Mastery of this technique requires throughout the understanding of experience in hip arthroscopy. Continuous learning and adaptation of the latest advancement are essential for achieving the best result. Ongoing research and innovation in arthroscopic technique and instrument will continue to enhance the effective and efficient of labrum repair and augmentation procedure. Thank you for your attention.
Excellent technique and presentation, Professor Uchida. I have one question. When you are pulling the thread through the anterolateral portal, where was your scope at that time? In which portal you keep the scope? Because you are using only two portals, and mid-anterior portal and anterolateral portal.
Yeah, that's a great question. I oftentimes using two portal, anterolateral portal and middle anterior portal.
No, but when you are railroading the graft, so your two sutures are in the mid-anterior portal and two sutures are in the anterolateral portal.
Yes.
But then that time, where do you keep your arthroscope?
Arthroscope is middle anterior portal or anterolateral portal. That's
No, means while pulling the graft, you take out the scope. Just
no. Anterior viewing from anterolateral portal, and the graft pass through the middle anterior portal.
No, but your two sutures are in the anterolateral portal then, because
Two suture.
how you pull the graft from the mid-anterior portal to the anterolateral portal?
That's why I show you that before slide. The suture, leading suture is anterolateral portal. And then
But in the anterolateral portal, you are using that for viewing. You are using the anterolateral portal for viewing.
Suture passes through the anterolateral portal and pulling out, and then leading suture through the anchor, and then.
Okay.
Yeah.
You don't use the DALA portal, that is distal anterolateral portal, for the anchor placement and suture management?
Usually the DALA portal I'm using it like only posterior part of the acetabular limb only, but now we can use curved guide. So I rarely use DALA portal.
Okay. Thank you, sir.
Thank you.
Thank you, sir. It was a wonderful presentation, especially that taking the thumb out,
Sir, can I ask
having
one
180
question?
degrees of the rotation on the arthropias is very nice.
Yeah.
I would like to know what is the how do you predict
One question.
how do you predict the attrition
Can I
of the
ask one
labrum?
question?
is that decision making done on the table, or do you do it preoperatively?
How do you predict? How do I predict? What do you?
Attrition, the labral attrition, the hypoplastic labrum. Is
Okay.
it done preoperatively,
Hypoplastic,
or do you
hypoplastic
do you
labrum.
hypoplastic
Okay.
labrum?
Okay.
Yeah.
Okay. I see. I understand.
When do you decide this gets repair, this gets augmentation? Yeah.
Okay. Okay. That's great question. So hypoplastic labrum is on the polyoperative MRI. We can project. I usually measure the size of the labrum width, and then this patient have a labrum hypoplastic labrum, and then I think we have to explain the patient. You may need undergo labrum reconstruction or augmentation. And then finally, consequently, the arthroscopic finding is really important to make a decision to labrum augmentation. Do you understand what I mean?
Yes.
Thank you, sir. Yeah, thank you. Yeah, I got it. Yeah, thanks. Yes, Naresh, go ahead. You had a question.
Sir, in hypoplastic labrum, whether do you remove completely the hypoplastic labrum and put a new reconstruction graft, or over the hypoplastic labrum add on the graft?
Okay. Usually, hypoplastic labrum is we believe the hypoplastic labrum is a circumference fiber between the normal labrum. Only segmental hypoplastic labrum region we do our augmentation, but
Okay.
we think the deep the native labrum is really important to maintain the circumference fiber to connect the native labrum. That's why we don't take the native labrum out and then keep the native labrum, and then reconstruct just behind the native labrum.
Okay.
Professor, do you repair the capsule post augmentation?
Yeah.
You close the capsule? Hello?
Sir, Professor, you have muted yourself.
Yeah, only repair the map photo. Sorry about that.
Professor, do you repair the capsule post augmentation or post labral repair? Do you close the capsule between the portals, mid anterior and anterolateral?
Only mid-anterior portal repair.
Only mid. Okay.
Yes.
So, do you use PDS or the harder sutures like fiber wire or something like that?
Yeah, I usually use ultra blade. Ultra blade is a strong suture.
Ultra blade.
Yeah.
Or fiber wire. Yeah.
Okay. Yeah.
Number 2 suture.
Professor, great talk. I have a question for you. Now you have a labral repair, you have labral augmentation, and you have labral reconstruction. So that means labral debridement is out of option for you nowadays. You just you just debride the labrum and leave it. Do you still do that, or always reinforce with augmentation if it's a hypoplastic labrum? Let us say the patient has isolated pincer without contralateral junction disruption. So there is only isolated pincer. There is labral crushing, not a gross torn labrum. It's only labral crushing as you usually seen in a pincer kind of lesions. So what do you do then? Let us say the labrum is normal, not hypoplastic or marginally hypoplastic, but there is a labral crushing. But there is no contralateral junction disruption. What do you do then?
Oh, thank you.
Because that is a question, that is a scenario in Indian population usually, because we have a lot of patients with isolated pincer, and since we have this financial constraints, we tend to do just a debridement, not to go for repair, because the control level junction is intact, so seal effect is still intact. So what do you do then?
Oh, that's great question. I think in Japan, only idiopathic osteosclerosis patient is like a pincer, greater global pincer, severe global pincer type of impingement, like ossification of the labrum, the patient. I think we can only debridement, labrum debridement or limb trimming is enough for those patients, because the pincer type of impingement is bony stability is good enough to the patient. And then even though I have experience of the global pincer type of impingement, I repair or reconstruction, the labrum reconstruction for those patients, but 5 years after surgery, those labrum graft become ossification. That's why I stop doing a labrum reconstruction of those patients. Yeah.
Probably that is why you didn't present that.
Yeah.
Yeah. Right. Okay.
Yeah. That's a great question.
Thank you. Thank you, sir.
I think we'll move on to the next presentation. Thank you, Professor. And now
Thank you so much.
Now I'll have Dr. Raghavendra from Mysore on interesting case presentation on how to manage arthroscopically the osteomyelitis of acetabulum with iliopsoas abscess. Over to you, Dr. Raghavendra.
Thank you. Can you see my slide?
Yeah, we can see it. We can see it. We can hear you.
Right.
All
Okay.
perfect. Yeah.
Right. Okay. Thank you, IAS again. Thank you, Dr. Naresh, for giving this opportunity to talk on hip arthroscopy. It's always a pleasure and honor to talk along with Japanese pioneers in hip arthroscopy. I'm particularly very happy to present this case, not only for the rarity of the case it has, but the excellent result I got after the surgery. The patient is very happy, so am I. So my name is Dr. Raghavendra Kimbavi, and I'm working as a consultant arthroscopy surgeon in Mysore, ABC Super Specialty Hospital. And I'll be talking on how did I manage arthroscopically in a case of acetabular osteomyelitis with iliopsoas abscess with a 6-year-old history. So I would like to acknowledge my colleague from Mysore Medical College, Dr. Giridhar sir, for giving me this case for referring this case to operate. So my patient was a female patient. She is a 28-year-old housewife, presented with a pain in the left hip since 6 years. She had a difficulty in walking or sitting cross-legged and squatting. She also had a night pain. There was no history of fever, evening rise of temperature, or any other constitutional symptoms. There was no other joint involvement. And on past history, there was a couple of surgeries being done to diagnose hip condition for underlying pathology twice, and there was no positive reports on the previous surgeries. So on examination, patient had an antalgic gait. There was no obvious deformities. Joint line tenderness was present. Range of movement were terminally painful, and impingement, flexion, adduction, internal rotation was positive, and the stent field test, which I do for iliopsoas impingement, was positive as well. Blood investigations, ESR and CRP were were on the higher side. ESR was 30 and CRP was positive 15. So that was showing some underlying infective pathology. Counts were within normal, and having a look at the X-ray, I didn't find any obvious infective pathology on the left hip. However, there was marginally reduced centrage angle on the left side. However, on the right side, it appears to be normal, but on the left side, it was around 22 degree. So that could be because of the previous surgeries, open surgeries, where they did biopsy or took up some bone from the superolateral part of the sternum. That could have been the reason for centrage angle being low on the lower side. And on the lateral view, Dunn's 45-degree lateral view, I found out small cam lesion as well. Apart from that, X-ray was relatively normal. And MRI in all sections showed fluid signals and axial in the coronal and in sagittal as well. So there was a lytic lesion with the erosion in the superior dome or anterior superior quadrant of the sternum, and the fluid signals were as high as in the iliac ring. So that was suggestive of some iliacus muscle collection as well as the psoas muscle. So based on clinico-radiological findings, my diagnosis was chronic osteomyelitis of anterior sternum with iliacus abscess on the left side, and MRI showed a collection of 7 to 8 cc fluid in the anterior superior quadrant of sternum, including the iliac muscle and psoas muscle, more on the iliacus muscle. And however, the hip joint showed normal on MRI, but I was not really sure about that because I was expecting some reactive effusion in the joint when I was able to put the scope, or there could be some infective pathology, but it was very mild. So my plan was basically to do arthroscopic debridement or decompression of the infection. So same time I was planning to do a synovectomy of the hip joint, take out some sample for culture and biopsy as well from the hip joint. And since I found out, it was not mandatory though, since I found out a small cam lesion on the 45-degree Dunn's view, I was planning to do a cam osteoplasty as well. And moreover, the patient was impingement positive. So now the challenge here was how to access the infective pathology. So my initial plan was to do it from the central compartment. That is, I was planning to do a couple of drill holes or with a bone hole from the central compartment because it looked easier MR-wise because the collection was just here. And so I was planning to do a couple of drill holes from the anterior superior quadrant. And I was pretty sure that because it was not a weight-bearing area, so I was thinking that this could be relatively safer. And if that fails, then I was planning to do a decompression of this collection from the anterior superior part of the rim, just adjacent to the labrum, without disrupting the contralateral junction. That was my initial plans to decompress the infection. And regarding the iliacus abscess, I was planning to do like it was on the left side, so I was planning at 9 o'clock position. I was planning to do a debridement of iliacus muscle and bursa around that. And I was also planning to go all the way up to the iliopectineal eminence. But going above that, from to the origin of iliacus muscle could have been very difficult. So this was my initial plan to do arthroscopically. And we had just interesting talk on capsular management by Dr. Takahira. So here I did measure the capsular thickness on the both side. On the right side, we can see this is normal, and we can see the clear space between the capsule and the head and neck junction. However, on the left side, it was quite thick. It came around 10 mm. Which was on the higher side. On the right side, it was around 2.5 mm. So this could have been, this capsular thickness could have been probably because of the two previous older surgeries. So we could have expected the capsular fibrosis and thickness following the surgery. Now, this was very important for me because I started my hip arthroscopy with the outside-in capsulotomy technique. Then I got trained from Dr. Michael Dienst. Then I shifted to peripheral compartment first technique. So here I thought PC first, that peripheral compartment first would have been very difficult because we hardly have a space between the capsule and the neck here. So I was planning to do outside in capsulotomy first. So outside in capsulotomy first, as described by Dr. Tawana et al. In 2014, using a weaving podial anterolateral and putting a scope just under the anterior superior part of the neck, under the tensor fascial lata between the gluteus medius and iliocapsularis muscle. And that's a bare area, literally. We don't have any muscle attachment over this part of the capsule. We have only capsule and we have overlying fatty tissue. So relatively, this area to access the head and neck junction is very easier compared to other areas as we do not have any muscle attachments here. So to begin with, so radio frequency came very handy here. So doing a capsulotomy from the anterolateral portal with scope being the anterolateral portal and instrument being in the anterior portal, mid-anterior portal. So next step was to do a capsular thinning because I wanted to increase my maneuverability of a scope and increase the working space. And at the same time, I was planning to take some synovial tissue biopsy for the culture and biopsy as well. So capsular thinning using the aggressive shaver here took some amount of time for capsular thinning. And since I was planning to do a cam osteoplasty, I did the cam osteoplasty here with a reverse mode. Bone being very soft here, so I used a reverse mode. So at the end of cam osteoplasty, we have this picture of cam osteoplasty. So I was happy with cam osteoplasty being done. Then I moved on to the central compartment. So there was no chondral or acetabular cartilage discontinuity or any damage here except the cartilage being soft. And surprisingly, I found out a bit of amount of sorry. That's a softening of the cartilage, and I found out a bit amount of cartilage labral fraying here, probably again because of the previous surgeries. And surprisingly, the labrum was quite thick and wide, just like we find in a dysplastic hip. So I'm not very sure this whether this labral anatomy could have been pre-existent dysplastic hip or could have been due to previous surgeries. Then I put all, like was my plan A to decompress the collection. I used all, but I didn't find any collection in this method. So after that, I just did a shaving of a frayed part of the cartilage. So next step was to decompress because I didn't find anything from the central compartment collection. So I moved on to the plan B. That's putting the shaver in the superior lateral rim of the sternum. And as soon as I put the shaver here, we could see that a lot of fluid came. So that is probably our collection here. So thick serosanguinous fluid, the bone being very soft here. And I was pretty sure that I was not disrupting any chondrolabral junction here. So I just went lateral to, superior to the labrum on the bony rim and decompressed the cyst as much as possible. So I spent a bit amount of time here, used all as well to decompress the collection. So I was pretty sure that I got a lot of unhealthy tissues and the collection as well. So this was decompression of the infection. Now, next step was to go for the iliopsoas. Now, as I found out on the MRI, there was iliopsoas collection here as well. So, as we can see, the iliopsoas muscle is quite thick and erythematous. We can see a lot of vascularity and synovial tissues around that. So, as a shaver, to thin out or partially release the iliopsoas muscle, and bursa around that to debride. Then I used the RF, and while I was doing that, I got some amount of collection here as well. So that's unhealthy fluid. As you can see, that's when I put a RF in iliopectin eliminates. So that was a unhealthy fluid which came out finally. So this was the end of my surgery, and I was very happy that I got some tissues, I got some debridement, and cam osteoplasty as well. So the very happy part of this surgery was I got a positive culture report as well as a biopsy report. So culture came as MRSA as usual, a very common organism, and tissue biopsy showed chronic synovitis with villus hyperplasia. Now, post-op protocol, I had kept a drain for a week nearly. It kept on coming. So that shows that the residual infection could have been taken out completely. And like any chronic osteomyelitis cases, I wanted to put for a longer duration, injection linezolid for nearly 4 to 6 weeks. But due to financial constraints, I had to reduce it to 3 weeks. And I shifted to oral for another 3 weeks. And I had kept her on skeletal traction for 3 weeks, non-weight bearing for 6 weeks, and passive ROM from day 1. So this was my 6 weeks post-operative images. As we can see, all the movements are free. Patient is very happy, including the impingement test, flexion, adduction, interrogation, no pain. And patient was able to sit cross-legged. And this test I did for iliopsoas impingement as well, Stinchfield test, and again there was no pain in the left hip. So regarding the discussion, acetabular osteomyelitis is quite rare. There is only one case reported on arthroscopic management of acetabular osteomyelitis so far. That was in 2021 in a pediatric patient, 10-year-old. And here,
we can't hear you, Dr. Raghavendra.
Sir.
You can hear now?
Yes,
Yes. Sorry for that. So here the case was pretty much similar to my case, but there was acetabular discontinuity in anterior superior quadrant of the acetabulum. So what they did was thorough debridement of acetabular erosion or acetabular involvement, and they created a defect of 8 to 10 mm. And with this, they didn't have any problem. So the very take-home messages from this case report is surgical planning is must to know the location of the lesion. And final defect here was 8 to 10 mm. So they didn't have any problem with that because they got an MRI after 2 months and they clearly showed ingrowth of the bone into the defect and new fibrocartilage formation at the cartilage deficit. So we should not be worrying much if we are decompressing from the articular side as well, because the decompression of the infection is a foremost thing. And arthroscopic release of iliopsoas muscles. This is a review literature in 2021, and these are the most common indications: internal snapping or internal coxa sultans, labeled as secondary to iliopsoas impingement. And the third most indication being, or probably this is the most common indication nowadays, iliopsoas impingement following total replacement. That is secondary to larger cup or retroverted cup or antiverted stem. And they clearly showed that in comparison to the open iliopsoas release, they have a decreased failure rate, fewer complications, and improved outcome. So to conclude, acetabular osteomyelitis as such, it's a very rare problem. Hip arthroscopy is a very effective procedure for the acetabular osteomyelitis, providing excellent view and access. Proper planning is must with respect to MRI. So we have to know where exactly is the location rather than going putting a scope and searching for the lesion. And of course, we have to have a proper post-operative. Thank you so much.
Thank you, Dr. Raghavendra. That was excellent case presentation. It was very interesting. I have a few questions if can ask you.
Okay.
So yeah, one thing is, was an ultrasound guided aspiration before the surgery essential for these cases? Second thing is use of intraoperative ultrasound to find out the right spot. What is your thought about these two things?
No, I didn't use any intraoperative ultrasound to diagnose a lesion because MRI, it gives a three-dimensional access. So MRI was quite enough for me to know where exactly was the lesion. The first question was, sorry, I didn't
First
hear.
question was, why didn't you aspirate ultrasound guided aspiration?
Actually,
there was an abscess.
Yeah. It was around 78 ml. And moreover, that there were 2 prior open surgeries being done. So rather than me going for putting a needle and trying to aspirate, I knew that it could have been not yielded me much because there were 2 open surgeries being done and both were negative results. So I thought I'll just put a scope and I thought I'll get something out of it.
And one more critical question here. There was this is a clear-cut case of infection.
Yes.
And do you think CAM osteoplasty here is warranted? Because aren't you introducing endogenous stuff? Yeah. I was just curious. Nothing critical.
As I already mentioned before you asked me, it was just a part of surgery. I mean, I could find out some CAM lesion and impingement was positive. And it was not a mandatory part of the surgery, but
correct. Although you had good results.
I had a very excellent result. I'm very happy.
Correct. Thank you so much.
And one of my doubt, can the thickness of capsule or thick capsule can be the reason for decreased range of motion or pain?
Yeah, definitely capsular pathology can be a very reason for the painful hip. But here the movements were free, but only thing is they were terminally painful. There was no restrictions or no deformity whatsoever.
Dr. Satish sir, do you have any questions?
No, I want to ask just one question because since it was an abscess, so whether it's means logical to do osteoplasty in such condition because in the case of
he answered that
we usually don't do such thing because of fear of spread of infection into the normal part of the joint. That's what my worry was.
I think I already answered that, but it was not a mandatory procedure.
But the results were good though. That's not
That's a very good.
Future, I was worried whether whenever there is abscess or infective lesion, whether we should do osteoplasty such type of things.
Yes. Should not. I mean, may not be required. But because that was not the pathology which was causing her pain. The main pathology was
abscess.
Infection. Yes, infection.
Correct. So, I think it was excellent discussion. There is a question from the audience.
One of the question.
I have a question about: do you close the capsule in Ehlers-Danlos patient?
Hello, everyone. My name is
Dr. Negayama. There is a question by Dr. Mason. He is asking about closing the capsule in a Ehlers-Danlos syndrome patient.
May I introduce myself?
Please go ahead, Dr. Mason. Yes.
My name is Mason. I was
Professor Sochi fellow last year. I spent some time with him, and also same time with Dr. Nalesh as well. So nice to see everyone here. I have a question to Dr. Sochi, because I think this is about closing session, right? So it's not
Dr.
about this
Mason,
patient.
Dr. Sochi is not there. He left
Can you hear
the
me?
webinar. He had to attend early morning surgery tomorrow, so he is not there in the webinar.
Oh, he left already.
Yeah,
I
please.
see.
You go ahead.
He left already. Okay. So because next week I have a patient. She is early the lost patient. So my question is, when we close the capsule, do we have to do like plication of the capsule, not just close it, just retight the capsule more than usual? You have any idea? You guys have experience about closing the capsule in capsular laxity of the hip?
I think, Dr. Mason, I think capsular plication is a different entity. It is usually done for the generalized laxity patient or capsular related instability patients. They do capsular plication. I think capsular closure is normally done procedure for whenever we do hip arthroscopy. Capsular plication, yes. Capsular related instabilities like isolated capsular general laxity patient, generalized lax patient. You have a lot of a few studies on capsular plication, putting 3 stitches horizontally. Yeah. Without anchors.
Okay, and after plication, the rehab program is changed from typical closing capsule.
Yes.
In terms of motion, about the time frame of moving the hip. You think should I delay the rehab or not?
Yes.
I see. Thank you.
Satish sir, do you have any thought on this? As Dr. Mason is asking about capsular instability, like a patient with Ehlers-Danlos syndrome. Is there any role of capsular imbrication or tightening the capsule, over tightening the capsule?
I think Dr. Satish is not available, Naresh.
Yeah. See,
Yeah.
Dr. Mason, I do agree with your thought that in Ehlers-Danlos syndrome patients, there is more of capsular laxity. There is always a chance of over tightening the capsule because the capsule will again become loose. In my opinion, I do over tight the capsule and keep the range of motion late, and physiotherapy will be slow, so that the actual capsular texture and the tightness can be re-attained or re-achieved. Satish sir,
Yes.
your thought on this, please.
I think in Ehlers-Danlos syndrome, better not to repair the capsule because though there is a capsular laxity, but even if you repair the capsule over the period of the time, because of this the type of the collagen, and it will further get loosened.
Okay.
So,
Sir, my doubt is, what about instability if we don't repair the capsule?
the physiotherapy and the rehab will manage the things. But at the most, you can repair the capsule between the as Dr. Sochi has said, that the capsule
Can be closed.
Yeah.
Thank you so much.
Thank you. Yeah, thank you so much, Dr. Mason. Yeah.
alongside. Hello.
Thank you.
Okay, Naresh.
Sir, yes, sir.
Naresh, are you here?
Thank you.
Yeah, sir. Satish, sir.
Sir.
Yeah. So
Yes.
I think
So
I
please
think
do that capsular reaping or shoulder. Hello. Prakash.
No, sir. You were saying something. You can finish it off.
No. Do you also prefer doing a capsular reaping or plication just like we do in a hyperlax shoulder in such type of patient?
No, I think I don't think there is a specific answer here because this is a special case, and nobody will exactly be able to tell what is right. So I think we'll have to preserve the natural laxity of the patient and just do a capsular closure, interportal closure. I think is better. Yeah, and then leave it alone. And
that was I am saying that at the most we can do a interportal capsular closure, but not like a shoulder a complete capsular plication and reaping like this.
Correct.
Right, sir. Thank you for your wonderful opinions and thoughts, sir.
Yeah.
Prakash, sir, please.
Yeah. I think we had a very nice session today. It was all insightful.
Yeah. Prakash left. Okay. Thank you. Thank you. Thank you for the.
Thank you very much. Thank you everyone for joining us. This is a very wonderful discussion. Hip arthroscopy is growing very fast in India.
Yes.
Thank you, Indian Arthroscopy.
Thank you.